We've taken an approach of trying to look at whatever we do and have tried to find ways to work as a team to make it better for our babies and their families, as well as our whole healthcare team. So for instance, to improve our respiratory outcomes for our preterm newborns, these babies, as you know, are at risk for developing a very serious form of a lung disease called bronchopulmonary dysplasia, or chronic lung disease or prematurity. So we've adopted an approach that's less invasive to support the respiratory care of these really fragile babies. We start from the very beginning with partnering with our colleagues in obstetrics and maternal fetal medicine to make sure that all mothers eligible to receive prenatal steroids do receive them in a timely fashion. We also perform delayed cord clamping at the delivery room, and we have an excellent team that attends all high-risk deliveries to help resuscitate the babies effectively yet very gently. Now, we perform simulation training all the time for our team members, and not just training so that they can perform the neonatal resuscitation or NRP correctly, but also we do extensive team steps training to enhance safe and effective communication. So from the very start in the delivery room, we also use T-piece resuscitators that pay particular attention to the amount of pressure that we're using to help resuscitate the babies. We also use bubble CPAP, as well as administer caffeine therapy very early. All these interventions really help our babies have the best start. Most of our preterm infants are effectively stabilized on nasal bubble CPAP, and we are we're markedly reducing the number of babies that we actually need to perform endotracheal intubation in the delivery room, which is really great because we know that time away from a mechanical ventilator is the key to reducing their lung disease. So since April of 2017, we've been administering a drug called surfactant to our premature infants through a very thin catheter while the babies are spontaneously breathing on nasal bubble CPAP. This less invasive surfactant administration, or LISA, has been shown to reduce the need for mechanical ventilation, reduces lung disease, and this has been used throughout various parts of the world. And it's become a very effective part of our overall respiratory care strategy here at Miller Children's and Women's Hospital NICU. And I'm proud to say we're one of the leading centers in the Western United States. We've performed this on a few hundred babies in the last 3 years, and this is due to our large volume of premature infants. For those babies that do need to go on to mechanical ventilation, we have an approach that's data and evidence-based to reduce the volume of air as well as the pressure with which we ventilate our babies. We use high-frequency ventilation, both the oscillator as well as the high-frequency jet ventilator for our tiniest babies. So with these and other strategies, we've seen a marked reduction in babies that have bronchopulmonary dysplasia, as well as babies that may need to go home on oxygen. So for those few patients that do need oxygen at home, we have an excellent pediatric pulmonary department that provides close follow-up in a multi-specialty clinic for patients with BPD, as well as patients with other respiratory illnesses that need close follow-up. Another focus of ours here in our NICU is nutrition and feeding. That's a primary focus for us as well because we really know that that's a key to improved outcomes for our babies. So we have an exclusive human milk program here, and with all of our feedings being prepared in a specialized milk lab here right next to our NICU. This milk lab is staffed with dedicated technicians as well as dietitians to provide all the fortification and the unique nutritional prescription that our babies need. In addition to that, we have an exclusive, human milk approach utilizing donor milk or, milk that's been donated and pasteurized, and we have a human milk fortifier that's also made with human milk. And both of these are part of our strategy to improve the tolerance of the feedings that we provide to our preterm babies, as well as reduce their risk of intestinal injury. For babies that are premature or other babies that have some difficulty with feeding, we have a technology that we use here called the N Trainer. And for our premature babies, this helps to organize their feeding skills so that they can gain those milestones a bit earlier and shorten their time here in the NICU. Now, there are some babies who do experience real difficulty with oral feedings, and so we have a whole team of pediatric and particularly neonatal rehab therapists that are occupational therapists, physical therapists, speech therapists to really help them. So we can evaluate the baby's swallowing in a very unique way without any radiation exposure, and we can simulate the true feeding environment using fiber optic evaluation of swallowing, FEES or FEES. So this is not just with bottle feeding, but also with breastfeeding. So this again is part of an overall strategy to really improve our diagnostic as well as our therapeutic interventions for feeding our babies. Families are a very big part of our NICU. And we all know that it's very difficult on families to have a baby in the neonatal intensive care unit. It's very, very stressful. And our families come from all parts of our community, and they have needs. They come from various backgrounds, various cultures. So we recognize this, and we work very hard to support all of them. We really look at our families as partners in caring for the babies in our NICU. So they're a big part of our team. We support the families in a variety of ways. We have support groups that they get together and have really candid and open discussions about what it's like to have the baby in the NICU. We also have NICU psychologists on our team for those families who are having a difficult time either bonding with their babies or dealing with the stress. We have a partnership with the March of Dimes, where we have an on-site March of Dimes family support coordinator and several volunteers who provide education as well as support to our families and put on a lot of activities for our families to be engaged in. And we have various other groups like child life support, music therapy. That's of course in addition to our medical social workers, our palliative care team. We have an excellent pastoral and spiritual care team. So we're really family-centered here.